Welcome back to the Deep Dive. We're here to take complex science, break it down, and make it stick. And I'm genuinely excited today because, well, we're tackling semaglutide. It's probably, the most talked about compound in metabolic science, maybe in the last 10 years. We've got a stack of sources, ready clinical trials, deep metabolic research, analyses on what happens long-term. Our goal, our mission for this deep dive is pretty clear. How does this GLP-1 receptor agonist, actually work? How does it change the body's energy game? We need to look hard at the evidence, the striking results for weight loss, for metabolic health, and maybe most critically, we need to face those really big open questions about using it long-term and, what happens when people stop taking it. This is all about getting clarity on something that's truly reshaping how we approach chronic metabolic conditions.
Absolutely. And look, before we dive headfirst into the mechanisms and the data itself, we have to lay down a really crucial boundary, a safety and regulatory one. It comes up in our sources, particularly those discussing where research peptides come from. We have to state this up front very clearly. Any peptides described by suppliers, like power peptides, which is mentioned in one source, these are strictly, and I mean strictly for research purposes only. That's the line drawn by regulators. It governs how they're distributed, how they're used. These substances are absolutely not intended for human consumption. Full stop. So we're here to analyze the science, the clinical results from controlled studies, but we need to keep that regulatory distinction clear in our minds throughout.
Okay, that's vital context. Thank you for setting that baseline that grounds us in the proper clinical research framework. Right then, let's get into the compound itself. Semaglutide. What actually makes this specific molecule so potent? Why has it become such a game changer in metabolic health?
Well, it really is a fascinating piece of biochemical work. Fundamentally, semaglutide is a synthetic analog. That just means it's designed to mimic a hormone our bodies produce naturally. That hormone is glucagon-like peptide 1, or GLP-1 for short. So scientifically, semaglutide falls into the class of drugs known as GLP-1 receptor agonists. We often just say GLP-1 RAs.
Right, I remember when GLP-1 RAs first started appearing. The initial focus, if I recall correctly, was pretty much entirely on type 2 metabolic dysfunction, primarily managing blood sugar levels. Was that the original goal for semaglutide too?
Oh, absolutely. The primary target initially was hyperglycemia, high blood sugar. See, naturally, your body releases GLP-1 from specific cells, L cells they're called, mainly down in the lower part of your gut, the distal small intestine and colon. This happens right after you eat, when nutrients hit the gut. It's part of your body's natural signaling system.
Ah, okay, so it's like a signal saying, right, food's arrived, let's get processing.
Exactly that. But here's the catch with natural GLP-1. It has an incredibly short half-life. There's an enzyme, DPCP4, that breaks it down within, minutes. Semaglutide, though, has been cleverly engineered. It's modified chemically so it resists that breakdown by DPP4. And it also binds really effectively to albumin, a protein in your blood. This basically protects it and extends its lifespan dramatically. That's why you get this really long half-life, which makes the convenient once-a-week injection possible. That longevity is, the first big practical advantage.
Okay, but the conversation now, the real buzz, isn't just about blood sugar anymore, is it? It's about these much broader effects, the really significant weight loss, the appetite control. How does it achieve that? Where does that systemic action come from?
It comes from the fact that GLP-1 receptors aren't just sitting in the pancreas waiting for sugar signals. They're actually quite widespread throughout the body. You find them in key areas of the brain, in the stomach, the liver, even in fat tissue and the cardiovascular system. So semaglutide, by activating all these different receptors, starts to influence the entire system of energy balance, or energy homeostasis. We can really break down its success into 4 main mechanisms of action. The first one, and this is often what people report feeling most strongly, is the powerful appetite regulation and its central effects in the brain. When semaglutide crosses into the brain and hits areas like the hypothalamus and the brainstem, these are key control centers, it activates those GLP-1 receptors. And activating those receptors directly dials down hunger signals and ramps up feelings of satiety or fullness.
So it's actually talking to the body's main control panel for energy intake and expenditure. What does that translate to experientially for someone taking it?
Well, the sources describe it as fundamentally shifting the relationship people have with food. It's not just about feeling full faster during a meal. It seems to significantly quiet that sort of background hum of chronic hunger that many people experience. It boosts satiety, that feeling of satisfaction that lasts after eating. And crucially, it seems to alter the brain's reward pathways related to food. You know, those really intense cravings for highly palatable stuff, fatty, sugary foods. The sources suggest semaglutide kind of turns down the volume on those signals. It appears to interrupt the hedonic drive, the pleasure-seeking aspect of eating, not just the basic hunger need.
That turning down the volume idea is really compelling. It suggests it's working on that neurological set point for hunger, which, let's be honest, has been a massive frustration for approaches relying just on willpower. Okay, what's the second key mechanism?
The second one is delayed gastric emptying. This is more of a mechanical effect, you could say. Semaglutide physically slows down the muscle contractions, the peristalsis, that pushes food out of your stomach and into the small intestine. So food literally stays in the stomach for a longer period.
Right, and I can immediately see a couple of benefits there. Feeling physically full for longer, that's one.
Exactly. That prolonged fullness reinforces those central satiety signals we just talked about. But there's a metabolic benefit, too. By slowing down emptying, you prevent that sudden, sharp rush of glucose into the bloodstream right after eating. You get a smoother, more gradual absorption curve. This helps avoid those big blood sugar spikes, which often lead to a subsequent crash and then, you guessed it, trigger another wave of hunger. And this slowing effect, the delayed emptying, also has really important implications for how other medications are absorbed. We definitely need to circle back to that later.
Okay, makes sense. Moving to the third mechanism, this takes us back to its original purpose, the pancreas. How exactly does semaglutide help manage blood sugar? And importantly, how does it do it safely, especially for people who don't have metabolic dysfunction?
Right. This is where we talk about the classic pancreatic effects. Semaglutide stimulates the beta cells in the pancreas to release insulin. But, and this is the absolutely critical safety feature you hinted at, this insulin release is glucose dependent.
Okay, can you unpack glucose dependent a bit more? What does that mean practically? Because that seems really key to its safety profile, particularly if someone without metabolic dysfunction is using it primarily for weight management.
It means that semaglutide essentially only gives the pancreas the go-of signal to release a significant amount of insulin when blood glucose levels are actually elevated, like after you've eaten carbohydrates. If your blood sugar is already normal or even low, the drug's effect on insulin release is minimal. It basically stays quiet on that front. This is incredibly important because it dramatically lowers the risk of hypoglycemia, dangerously low blood sugar. That was a major problem with some older diabetes medications, the ones that just pushed insulin out regardless of blood sugar levels. So semaglutide provides a much more intelligent, tailored response, matching insulin output to the body's actual current need. And there's another pancreatic effect. It also suppresses the release of excessive glucagon. Now, if insulin tells your cells to take up and use or store glucose, glucagon does the opposite. It tells your liver to release stored glucose into the blood. By putting the brakes on inappropriate glucagon release, semaglutide helps prevent the liver from unnecessarily raising blood sugar levels. And finally, there's some suggestive research, early days perhaps, but evidence suggesting that by reducing the overall workload and stress on the pancreatic beta cells, semaglutide might actually help preserve their function over the longer term.
Wow. Okay, so that combination, the smart glucose-dependent insulin release plus suppressing that glucagon alarm, that sounds like a really powerful 1-2 punch for metabolic control.
Right.
What about the fourth mechanism, the one you termed peripheral metabolism? How does it influence things beyond the gut and pancreas?
Yeah, this is where we see the benefits extending to overall metabolic health, beyond just weight or blood sugar numbers. Semaglutide seems to have anti-inflammatory effects throughout the body. We know chronic, low-level inflammation often accompanies metabolic dysfunction, and this compound appears to help dampen that down. It also influences adipose tissue function, that's your fat tissue. It affects how fat is stored, how it's mobilized and used for energy. And critically, it improves insulin sensitivity in peripheral tissues like your muscles and liver. This means those tissues become better at responding to insulin signal, allowing the body to utilize glucose and energy more efficiently.
Okay, so putting it all together, semaglutide isn't just like an appetite pill or a blood sugar drug. It's acting more like a systemic conductor,
That's a good way to put it.
orchestrating signals from the brain, the stomach, the pancreas, the fat cells, all trying to nudge the body back towards a more balanced energy state.
Precisely. It really shifts from being just a glycemic agent to being a broad modulator of the entire energy regulation system. And that's why the clinical results have been so, well, striking.
Let's pivot right there then to
Wow.
those striking outcomes, all this deep physiological tweaking. What did it actually translate into in terms of measurable results, the real-world data in the main group studied?
Okay, so we really need to look at two distinct populations here. First, let's consider individuals who already have type 2 metabolic dysfunction. For this group, the benefits for core metabolic control are clear and significant. The studies consistently show major reductions in HbA1c, that's your long-term blood sugar average marker. We also see lower fasting glucose levels, better post-meal glucose control, and definite improvements in key cardiovascular risk factors, things like lipid profiles getting better, blood pressure coming down.
But the sources make a really interesting point here. They note that the amount of weight lost in patients with metabolic dysfunction, while still happening, is generally less than what we see in people without it. Why that difference?
Yes, that's a key observation and an important clinical nuance. The thinking is that it likely relates to the underlying metabolic state in long-standing type 2 metabolic dysfunction. These individuals often have significant hyperinsulinemia, meaning their bodies are producing large amounts of insulin constantly and deep-seated insulin resistance. Over years, this metabolic environment has effectively trained the body to prioritize storing energy, often leading to a higher biological weight set point that's just inherently more resistant to change. So yes, they lose weight, but the magnitude is often somewhat blunted compared to non-diabetic groups. It's a tougher biological hill to climb for them.
Okay, that makes sense. So now let's talk about the results that really shook things up, the ones that redefined what was possible pharmacologically, the data in people dealing primarily with obesity and overweight, but without that pre-existing metabolic dysfunction. This is where those headline-grabbing numbers emerged, right?
Absolutely. This is undeniably where semaglutide has had its most profound clinical impact, certainly in terms of weight reduction. When you look at the major clinical trials, the S-STEP1 trial is probably the most famous example where participants used the higher doses of once-weekly semaglutide alongside standard lifestyle counseling. While the results were unprecedented for a medication, across these large trials, participants achieved an average total body weight loss somewhere in the range of 14% to 17% over about 68 weeks, so just over a year. And it's important to note that's the average. Some subgroups within those trials actually achieved 20% weight loss, or even a bit higher.
Okay, stop there for a second. 17% average weight loss from a drug. Can you put that number into context? Compared to what was available before, what does 17% actually mean? That perspective is crucial to understanding why this was so revolutionary.
It is revolutionary because that 14–17% range starts approaching the kind of weight loss efficacy we previously only really saw with bariatric surgery. Surgery typically aims for, say, 25–35% loss, but obviously comes with significant risks, invasiveness, and lifelong commitment. Before semaglutide and similar agents, the best available anti-obesity medications might achieve, on average, maybe 5% to 7% weight loss over a similar period. Intensive lifestyle and behavioral therapy alone typically yields around 3% to 5%. So semaglutide was essentially doubling or even tripling the effectiveness of the previous best non-surgical options. It represented a quantum leap in pharmacological efficacy for obesity.
That really is a staggering jump. And what about the type of weight loss? Was it just water weight or worse, precious muscle mass?
That was a critical question, and the body composition studies provided a clear answer. The overwhelming majority of the weight reduction came from fat mass. This is hugely important. It suggests the drug is effectively targeting the excess energy stores, the fat, while relatively sparing lean body mass muscle, which is metabolically active and vital for long-term health and function.
We know clinical trials are one thing, controlled environments, selected participants. How well do these results hold up in the messier real world? What do those application studies show?
Yeah, real-world data always provides a necessary reality check. As you'd expect, factors like varying adherence, cost issues affecting consistency, differences in lifestyle support, they do tend to moderate the outcome slightly compared to the pristine trial conditions. However, the effectiveness remains really impressive. Real-world studies generally report significant and meaningful average body weight reductions in the ballpark of 6% to 11% within the first 3 to 6 months of starting therapy. This indicates that even outside trials, the drug prompts rapid and substantial weight loss early on in treatment across diverse patient populations and clinical settings.
The number on the scale is obviously compelling, but let's tie this back to the bigger goal, reducing the risk of chronic diseases associated with obesity. What did the sources say about the broader cardiometabolic picture? Did those markers improve too?
Yes, absolutely. It wasn't just about shedding pounds, it was about systemic metabolic improvement. The sources consistently confirm significant positive changes in key objective health markers alongside the weight loss. We see sustained improvements in blood pressure readings, significant reductions in waist circumference, which is a good proxy for visceral fat, the dangerous kind around the organs. Favorable shifts in lipid profiles are common, typically lower triglycerides and often an increase in HDL, the good cholesterol. And importantly, measures of insulin sensitivity generally improve. Perhaps most critically, large outcome trials specifically designed to look at cardiovascular events in high-risk individuals demonstrated a clear reduction in the risk of major adverse events like heart attacks and strokes. So the evidence strongly suggests the compound isn't just treating the number on the scale, it's actively mitigating the downstream health consequences of excess weight and metabolic dysfunction. It's changing fundamental health trajectories.
Okay, this all sounds incredibly promising, almost like the magic bullet people have hoped for.
Right.
But now we need that reality check. Any potent medication that influences the body so profoundly usually comes with side effects and practical hurdles. Let's talk about tolerability first.
Yes, we absolutely must address the tolerability profile. This is the main reason people might stop taking the medication. By far, the most commonly reported adverse events are gastrointestinal in nature. We're talking about nausea, sometimes vomiting, abdominal discomfort or pain. Constipation is quite common too, and bloating.
And why the GI issues? Is that directly tied to one of the mechanisms we discussed earlier?
Yes, it's thought to be primarily linked to that delayed gastric emptying. Remember, the drug slows down how quickly food leaves the stomach. The body is essentially adjusting to having food sit in the stomach for much longer than it's used to. Because this effect is dose-related stronger effects at higher doses, the standard way to manage these side effects is through a very slow, gradual dose escalation, usually over several weeks or even months. This allows the digestive system time to adapt. And while for most people these symptoms do tend to lessen or resolve over time as their body adjusts, we can't gloss over the fact that for a small but significant minority of individuals, the GI side effects remain persistent and bothersome enough that they do choose to discontinue treatment. It really underscores the individual variability in response. What one person tolerates with minimal issue, another might find quite difficult.
Okay, so GI issues are the most common hurdle. Beyond those immediate side effects, what are the other major practical challenges or barriers people face when considering or using semaglutide?
There are several quite significant ones. First and foremost is the cost and accessibility. These medications are currently very expensive, and insurance coverage can be patchy or require extensive prior authorization hurdles. This creates huge equity issues, limiting access for many who could potentially benefit. Second, this isn't like a course of antibiotics. It requires long-term adherence. As we'll discuss, the benefits tend to reverse upon stopping, implying potentially lifelong use for sustained effect. That demands ongoing financial commitment, regular injections, and consistent engagement with healthcare providers. Third, and this is really important for patient safety, is that drug interaction insight related to delayed gastric emptying we mentioned earlier. Because semaglutide slows down digestion so significantly, it can potentially alter the absorption rate and timing of any other medication taken orally. This requires careful consideration and often dose timing adjustments for other drugs, especially those with a narrow therapeutic window or where rapid absorption is critical, like certain thyroid medications, heart rhythm drugs, or even oral contraceptives. Physicians need to be really vigilant about this.
Okay, all these practical points lead us directly to what might be the single most important piece of data in this entire deep dive. The finding that really reframes how we have to think about obesity itself. What happens biologically when someone stops taking semaglutide?
Yes. This data is stark. It's quite unambiguous, actually. And it's probably the single finding that most powerfully solidified the medical understanding of obesity as a chronic, biologically driven condition prone to relapse, rather than a temporary problem solvable by willpower alone. Studies that followed participants after they stopped their semaglutide injections revealed a remarkably consistent and swift reversal of the benefits they had gained. The most striking finding is the weight regain. On average, individuals regain a substantial portion of the weight they lost, commonly cited as up to 2/3 of the lost weight within about 12 months of discontinuing the therapy.
Hold on. 2/3 of the way back within just a year. That sounds like the body isn't just passively drifting back, but actively fighting to return to its previous higher weight. Is that how researchers interpret that rapid regain?
That is precisely the interpretation. It strongly suggests that the powerful biological mechanisms that defend body weight, the ones that contribute to weight regain after dieting, reassert themselves quite forcefully once the drug's influence is removed. It implies that semaglutide was effectively suppressing the body's underlying biological drive to maintain a higher weight set point, but it wasn't permanently resetting that thermostat. When the pharmacological brake is released, the body reverts towards its previously established, often higher, equilibrium point. This is driven by complex hormonal changes, for example. Studies show hunger hormones like ghrelin tend to rebound, increasing appetite, while satiety hormones like leptin and PYY might decrease. The body essentially perceives the prior weight loss as a state of energy deficit, a threat even, and initiates powerful counter-regulatory responses to restore the lost weight.
That really paints the picture of the drug acting almost like pressing a pause button on the underlying chronic condition, rather than offering a definitive cure. Does this reversal effect also apply to the other health improvements, the cardiometabolic benefits?
Unfortunately, yes, the data suggests it largely does. Those significant improvements we celebrated, the better blood pressure, the improved lipid levels, the enhanced insulin sensitivity, these also tend to regress back towards the participants' baseline levels once the pharmacological support of semaglutide is withdrawn. So, the big unavoidable takeaway from all this discontinuation data is that semaglutide and likely similar GLP-1 based therapies need to be viewed fundamentally as long-term management tools for a chronic condition. They effectively control the symptoms and consequences of that condition while being used, but they don't cure the underlying biology in a way that persists after stopping. It's much more analogous to how we treat other chronic conditions like high blood pressure or high cholesterol. The medication works while you take it.
Okay. Given that this weight regain upon stopping is such a central and significant challenge, what are researchers focusing on now? How are they trying to figure out ways to perhaps sustain the benefits, even if people can't or don't want to stay on the highest dose indefinitely?
That's exactly where a lot of the current research effort is directed. The strategic focus is on finding ways to uncouple the initial weight loss success from the subsequent regain. There's a lot of investigation into maintenance strategies. Can benefits be sustained using much lower, perhaps better tolerated and less expensive maintenance doses after an initial higher dose induction phase? That's a key question. Researchers are also looking very closely at combination therapies. Could adding another agent with a different mechanism during the maintenance phase help lock in the benefits? And there's a strong focus on enhanced lifestyle reinforcement. Can the period when the drug is actively suppressing biological hunger drives be used more effectively to deeply entrench sustainable behavioral changes, dietary patterns, physical activity habits that might have a better chance of persisting, even if the drug dose is later reduced or stopped? It's a multi-pronged approach.
Semaglutide clearly threw open the doors and set a new standard for GLP-1 therapy. But as you said, this field is moving at lightning speed. Let's shift our gaze forward now. What's emerging? What are researchers building on this foundation?
Right. Semaglutide really established the power of targeting the GLP-1 receptor pathway effectively. The immediate and most obvious evolution we're seeing now is the move towards agents that hit multiple targets simultaneously. So we're already well into the era of newer agents, particularly dual agonists. The most prominent example and the most relevant direct comparison to semaglutide right now is tirzepatide. Tirzepatide is different because it's designed to activate both the GLP-1 receptor and another receptor called the GIP receptor. GIP stands for a glucose-dependent insulinotropic polypeptide.
Okay, we know GLP-1 acts as a major brake on hunger and helps control blood sugar. What extra dimension does hitting the GIP receptor add to the mix? What does GIP do?
GIP is another natural gut hormone, also involved in glucose metabolism and potentially energy balance. Think of it perhaps as a complementary system. While GLP-1 seems dominant for satiety signals in the brain and slowing the gut, GIP might have additional or synergistic effects, possibly enhancing insulin secretion further, also in a glucose-dependent way, potentially increasing energy expenditure slightly, and maybe having more direct beneficial effects on fat cell health and function. The clinical trial data comparing tirzepatide to semaglutide suggests that this dual agonism hitting both pathways often results in even greater average weight loss than semaglutide alone. We're seeing mean efficacy figures that creep even closer to those achieved with bariatric surgery.
Okay, so if hitting 2 targets is better than 1, the logical next step must be hitting 3. Or maybe strategically combining different classes of drugs. Is that where the cutting edge is heading? Maximizing synergy.
That's absolutely the direction of travel. The research pipeline is very active in exploring combination therapies to achieve maximal biological effect by targeting multiple distinct pathways involved in energy regulation. A prime example being explored is pairing a GLP-1 RA like semaglutide with an amylin analog, such as a compound called cagrilintide. Amylin is another gut hormone co-secreted with insulin that acts on different brain pathways to promote satiety. Early studies looking at these kinds of combinations, like semaglutide plus cagrilintide, CagriSema, have shown really remarkable results. The amplified effects on appetite and potentially energy balance seem to be synergistic, with some trials reporting average body weight reductions pushing 20% or even higher. It really validates the hypothesis that because obesity and metabolic dysfunction are such complex, multifaceted conditions involving numerous hormonal and neural pathways, attacking the problem from several angles simultaneously is likely to yield the most profound outcomes.
Beyond just developing new molecules or combinations, are researchers still digging deeper into the fundamental science? Like, how exactly does semaglutide influence cells and tissues beyond the obvious appetite and glucose effects?
Oh, definitely. The sources make it clear that while we know the main mechanisms, the full picture of semaglutide's actions at the cellular and molecular level is still being mapped out in detail. Ongoing research themes include pinning down its precise effects on pathways related to chronic inflammation and oxidative stress, which are closely linked to metabolic disease. There's also significant interest in its influence on mitochondrial function, the energy factories within our cells, and understanding exactly how it might modulate overall energy expenditure, not just energy intake. Fully understanding these deeper biological effects will be crucial for refining future therapies, identifying potential long-term impacts, and maybe even predicting who will respond best.
You mentioned earlier that there's quite a bit of individual variability in how people respond. Some get fantastic results with semaglutide, others less so. How is future research planning to tackle that, to make treatment more predictable?
That observed variability is a major driver behind the push towards future personalization. The goal is to move towards a more precision medicine approach for metabolic health. The vision is that, in the future, we might use genetic profiling or specific metabolic biomarkers before even starting treatment. These tests could help predict which individuals are most likely to have a robust response to a GLP-1-based therapy versus maybe needing a dual agonist like tirzepatide, or perhaps benefiting more from a combination approach right from the start. It's about moving away from the current, somewhat trial-and-error approach, towards using biological insights to select the optimal agent and potentially even the best dosing strategy for each unique individual. This should maximize the chances of success and minimize time and resources spent on therapies that might be less effective for that particular person.
These advancements are truly exciting, but they also inevitably raise some really big, non-scientific questions and challenges. As these powerful therapies become more common, what are the crucial open questions that the medical community and society really needs to grapple with?
You're right. The scientific progress brings significant societal and healthcare system challenges. There are probably four major open questions or challenges we absolutely have to address. First, we desperately need more robust long-term data. Can lower, potentially more affordable, and better tolerated maintenance doses truly sustain the weight loss and the crucial cardiometabolic benefits over 5, 10, maybe even 15 years of continuous use? We just don't have that data yet. Second, we have to find better solutions for the weight regain problem. Are there effective therapeutic strategies or maybe intensified behavioral protocols that can genuinely help prevent or significantly mitigate that biological rebound effect if and when therapy needs to be stopped for any reason? Third, related to the first point, is understanding the long-term systemic effects. What are the potential consequences, if any, of activating GLP-1 receptors continuously for years or even decades on various tissues, heart muscle, bone density, thyroid function, the immune system? While the current safety data over several years looks generally reassuring, ongoing vigilance and dedicated long-term surveillance studies are non-negotiable.
And the fourth one, which you touched on earlier, feels like maybe the biggest immediate hurdle: access and cost. These drugs are transformative, yes, but also incredibly expensive. How can we possibly expand access equitably to address the sheer scale of the global obesity and metabolic disease crisis without completely bankrupting healthcare systems?
That financial and logistical challenge is enormous. It's probably the single greatest non-scientific barrier right now. Finding sustainable solutions will likely require a combination of strategies over time, potentially price negotiations, maybe eventual generic competition many years down the line, and innovative coverage models. How we navigate this will largely determine how widely this new era of effective metabolic medicine can actually be implemented.
Okay, that brings us towards wrapping up this deep dive. If we try to distill it all down, semaglutide emerges not just as a weight loss drug, but really as a sophisticated precision tool. It acts like a powerful mimic of a natural hormone, helping the body find a better energy balance by dialing down hunger signals from the brain, slowing down digestion, and managing blood sugar more intelligently.
And crucially, as all our sources emphasized, it works best not in isolation, but when it's integrated as one part of a comprehensive, multi-pronged strategy. It's a potent instrument that makes significant weight loss and metabolic improvement achievable for many, but its success is amplified and sustained when combined with the essential foundations. Appropriate dietary changes, regular physical activity, and often ongoing behavioral support. It enables change, but it doesn't replace those other pillars.
And if we step back and look at the really big picture here, the profound impact of semaglutide and these related therapies goes beyond just the medical charts. It feels philosophical almost. The sheer weight of the clinical evidence provides undeniable objective proof that body weight regulation is deeply biological. It's powerfully governed by hormones, by brain chemistry, by complex metabolic signaling networks.
Yes, and that evidence really mandates a fundamental shift in how we think about and talk about obesity, both culturally and medically. It forces us to move decisively away from the old, frankly often blaming paradigm that treated obesity primarily as a matter of personal failure, a lack of willpower. Instead, the science firmly establishes obesity for many people as a chronic biologically driven condition, one that, like other chronic diseases, often requires sophisticated medical intervention and ongoing long-term management strategies.
A much-needed paradigm shift indeed. Okay, let's end with a final provocative thought for you, our listener, to mull over. We've discussed how the sources highlight significant individual differences in how people respond to semaglutide. And we've heard that the future points towards personalized treatment using genetic or metabolic profiling. So, here's the question. As we move towards that world of truly personalized metabolic medicine, what are the big ethical or practical hurdles we need to confront? For example, who gets access to that kind of detailed profiling? Who decides? And what happens practically and ethically for individuals who might be identified through profiling as likely non-responders to these powerful cornerstone therapies? Where do they turn?
That is a massive question. How we handle the ethics of personalization, predictive testing, and ensuring equitable access to the right treatments, that's going to be central to healthcare debates for years to come.
Something to definitely keep thinking about. Thank you for joining us on this deep dive into semaglutide. Just before we sign off, one final essential reminder regarding the scope of our discussion today.
Yes, please remember that all the information we've discussed is drawn directly from scientific research sources and is presented here for informational and analytical purposes only to help understand the current state of the science.
And as we stated clearly at the beginning, any products mentioned as being available from research suppliers are designated strictly for laboratory research use. They are not intended for human consumption.
We really hope this deep dive has offered you some valuable clarity and depth on this rapidly evolving area of metabolic science.
Until next time, stay curious.